Thank you, and greetings. Welcome to today's presentation titled, The Root of Poor Youth Mental Health Outcomes, How Public Health Goes Upstream and Convenes Cross-Sector Partners. Before we begin, there are a few housekeeping items I'd like to quickly go over. This presentation is being recorded, and the recording link, slides, and a letter of attendance will be sent via email to everyone who attended today. This information will also be available on ASTHO's, NAMI's, and NASHBID's websites and NASHBID's YouTube channel. Please use the chat pod to share your name and state, ask questions, and/or share information with the group that pertains to the presentation. Closed captioning can be viewed the link in the chat pod. We also have an ASL interpreter who is spotlit on everyone's screen, at least I'm hoping so. After the presentation ends and you leave this platform, a brief survey will show in your browser. Please take a few moments to share your comments and thoughts about today's presentation. We would like to give special thanks to SAMHSA, excuse me, for sponsoring this series. And again, thank you for joining us. I will now turn this over to Ioana, Senior Analyst at ASTHO. Thank you.
Hi, good morning and good afternoon, everybody. Thank you so much for joining. As Kelly had mentioned, this webinar is part of a webinar series around leveraging different sectors to address youth mental health crisis. This is the first as part of this series, and we're really hoping to talk about how we can work towards upstream prevention using the public health sector. Next slide. This webinar is funded by SAMHSA, and the views, policies, and opinions expressed are those of the authors and do not necessarily reflect those of SAMHSA. So I just wanted to make sure we kind of outlined that from the beginning. Next slide. A little bit about the Association of State and Territorial Health Officials who's sponsoring this webinar. We are a state association that represents chief health officials over their states, and we support, equip, and advocate for state and territorial health officials in their work of advancing the public's health and well-being. And we do this through national products like the one you're seeing today, as well as other technical assistance like learning communities and one-on-one site visits and other things for states to support them in their work. Next slide. Today, I'll be your moderator, and we do have three wonderful speakers. We have Eva Bland from our partners at Safe States Alliance, as well as Jared Parrish and Patrick Sidmore from the Alaska State team. And we welcome their expertise around youth mental health and how public health can work upstream to address these issues. Next slide. We hope to increase your knowledge about the role of public health, and that you can learn from the state example about how public health agencies can improve youth mental health data, systems, policies, and programs. And since we have both Department of Education and Department of Public Health, we hope this will show you how cross-sector collaborations can be used to address comprehensive youth mental health systems. And at this time, I will turn it over to our first speaker, Eva Bland. Thank you so much.
Wonderful. Thank you so much. I appreciate that welcome. If you could go to the next slide, please. Wonderful. Thank you. Hi there. My name is Eva Bland. I'm a program manager at Safe States Alliance. We are a national nonprofit organization and professional association whose mission is to strengthen the practice of injury and violence prevention. Our vision is to be the recognized leader and driving force in understanding and preventing injuries and violence. So our members are state health, injury, and violence prevention professionals, researchers in the field, individuals working in nonprofits, doing similar work, and others working in injury and violence prevention. So I say all that just to set the tone that I am very much coming from a public health background, and I am very much coming from individuals working more at the state level. One of the things that brought us to this conversation was just the fundamental questions at the root of public health have been shifting away from addressing single specific issues and instead focusing on the systems that support well-being holistically. So today I'm going to talk a little bit about how that connects to youth mental health outcomes. Next slide, please. Thank you. And so many of you have already put your name in the chat, so thank you very much. And I've already introduced myself, so I think we're good on that. If you haven't put your name in the chat, I encourage you to do so. Next slide, please. Thank you. So just a few purposes and agreements as we begin this, just because I think it's nice for us all to be on the same level of understanding. One, just being willing to try on a different point of view. This takes a different approach to thinking perhaps about your work, a more upstream approach. So I hope you might bring your creative thinking hat while I talk. I'm hoping that many of you will be able to stay present. I know we do lots of online meetings, quite a lot, but hopefully you'll be able to stay present, write things down, and please use the chat. If you have a question, I'm going to try to keep an eye on it, but there's a lot of things happening. So if I don't get to it, I'll get to it at the end. And then finally, one thing I like to kind of preface this whole conversation with is that this is an emerging field of study. We're all discovering and learning when it comes to upstream prevention. So no one is an expert. I certainly wouldn't call myself an expert, but I hope that I will provide some information that will help you all. Next slide, please. Thank you. So I'd like to set the stage for this conversation from my perspective as a public health professional. Much of the work I do is in primary prevention. So when I'm talking about impacts and outcomes, I'm talking specifically about the impacts and outcomes of primary prevention initiatives. And these are usually population initiatives that address the underlying risk and protective factors to violence and injury. Next slide, please. Thank you. This is just another way of looking at what primary prevention is. I would imagine some of you may work more in secondary prevention or tertiary prevention, or maybe even in recovery. Primary prevention activities are activities that are happening before violence or injuries take place. So when we're talking about upstream prevention, which is what this webinar is kind of focused around, we're often talking about primary prevention. Next slide, please. So what does upstream prevention look like, and what does that look like for creating positive outcomes among youth? Next slide, please. Thank you. So the first place I like to start when describing upstream prevention is social determinants of health. Social determinants of health are the conditions and the environments where people are born, live, work, play, worship, age, and so on. Social determinants of health affect a wide range of health and quality of life outcomes and risks. So in my field, we focus on what we can do to best support a group. Let's take this family and the little red circle in the middle here. How can we prevent injuries and violence for this family? Social determinants of health tell us that we have to focus on all the factors that impact them. We have to think about the economic stability impacting this family, the neighborhood they're in, the education system that they interact with, the resource and goods that they have available to themselves, their health, their general health, so on and so forth. So social determinants of health have a major impact on people's health, well-being, and quality of life. And we know that just promoting healthy choices won't eliminate health disparities for this family. Public health organizations must work with their partners in sectors like mental health to improve the condition in this family's environment to prevent injuries and violence from happening. Next slide, please. But what if we're trying to support something larger than just that family? What if we're trying to prevent injuries and violence among the youth in North Carolina? For public health, I say North Carolina, I should say, because I'm currently located in North Carolina. So if we're thinking about population, we're really looking at the societal level of prevention. And so for public health practitioners, we look at building protective factors at the societal level. Examples of this in terms of impacting North Carolina's youth might include exploring programs that help build connectedness to safe and stable and supportive relationships. It might include policies that combat bullying, promoting legal frameworks to prevent violence and injuries against children, or even promoting and making sure there's access to quality education and resources for those youth. Next slide, please. So what are shared risk and protective factors and approaches? Knowing that upstream prevention has the greatest impact, how do we apply that to our work? Next slide. So many of you might be familiar to risk factors and protective factors, especially how they are connected to an individual's health. In public health, we think about these terms as it relates to larger health outcomes. And in recent years, as I mentioned at the beginning of this presentation, shared risk and protective factors are a way of thinking more upstream in prevention. We've begun to focus on this idea of shared risk and protective factors because they are characteristics or situations that impact more than one type of public health issue. Next slide, please. In terms of what that looks like, for someone who might be traditionally focused on child maltreatment and adverse childhood experiences, or what is commonly referred to as ACEs, outcomes which we know is connected to children and adolescent mental health. Shared risk and protective factor approaches encourages us instead to focus on protective factors, maybe such as coordination of resources and services among community agencies. Knowing that by doing so, you're not only focusing on ways to decrease child maltreatment outcomes, but also intimate partner violence, suicide, substance misuse, or even housing inequality. So again, we're thinking about this through a primary prevention lens. We're looking at ways to build protective factors at the societal level, so as to positively impact the social determinants of health. Next slide, please. Oh, number 17. Perfect. So this is a reality of the work that we find ourselves in with public health. Quite a lot of protective factors and risk factors out there impacting so many different health outcomes. Next slide. Thank you. But the benefits do outweigh the hardship that is trying to understand and do this work. There are many benefits to using a shared risk and protective factor approach for prevention, and it is why, as public health professionals, we are looking at this approach more in terms of how we frame our work and do our work. I'm not going to go through every single point here, but please be sure to look at this slide when you have them available to yourself. Next slide, please. So what does shared risk and protective factor approaches mean for public health? What does this look like as we go forward? Next slide. So as a field, we have progressively moved from siloed topic-focused areas to a collaborative public health 3.0 approach. Public health 3.0 also means that we have to acknowledge that systems of power impact our root causes, which then impact our health outcomes. With public health 3.0, it means that we have to acknowledge and look for the ways to improve social determinants of health. I think most importantly, especially for this webinar, as we're thinking about how public health and mental health sectors can work together better, where the way shared risk and protective factor approaches and upstream prevention have connected and moved this field of work forward, we're realizing that we have to engage with multiple sectors to help move this work forward. So that is my presentation. Next slide, please. I have my resources and references outlined here. I am happy to answer questions as we get to them. It was certainly a fast presentation, but I'm excited to hand it over to some partners in this work so that you all can get a little more of a state example of what this work looks like. So Jared and Patrick, I hand it over to you all.
Great, thanks. I'll kick us off. This is Jared Parrish from Alaska. Thanks for allowing me to come and share a little bit of time with you this morning or this afternoon, depending on where you are across the country. So what I'm going to be talking about is what we've done in Alaska related to the connection between Division of Public Health, and then Pat Sidmore is going to talk about his work with the Department of Education. Eva has talked about, or Eva, talked a lot about moving upstream for this public health perspective. And the visual image that I always have of moving upstream is this little trickle of water coming out of like a little water field, and it's really easy to divert or move that. But being from Alaska, what I've learned, when you move upstream, you find yourself facing a glacier. Moving a glacier is incredibly challenging, and you started getting some of that perspective of all these different factors that are moving into causing these challenges that we are trying to prevent or work on, which is why we get to the shared risk and protective factors. The public health model is built upon having a strong foundation of public health data or population-based data. And when we're talking about something this big, having a really robust, comprehensive data source is what we set out to do. And can we go to the next slide? So I'm going to share with you a little bit about what the Alaska Longitudinal Child Abuse and Neglect Linkage Project, or we call ALCAN-LINK because it's a mouthful. What we've done is we've integrated the Pregnancy Risk Assessment Monitoring System Survey, or PRAMS, from the 2009 through 2018 birth cohorts with administrative data sources, as well as a 3-year follow-up survey that we have to this. And we do this annually. We link to the permanent fund dividend, which allows us to track our population over time, our Office of Children's Services, which is our child welfare agency, our Department of Education and Early Development, our birth and death records, and also our vaccine records. I just haven't updated the slide yet. And then you can see this 3-year follow-up survey that we have. So we have this longitudinal prospective cohort that we're following over time to understand the factors that are contributing to early childhood health outcomes. The wonderful thing about PRAMS is that it asks about questions related to the pre-birth experience. And so when we talk about moving upstream and we're talking about improving the household environment, we really need to be thinking about before the kid's even born. So let's go to the next slide. So what we found with these data, when we've looked at kids that were born between 2009 and 2018, if we follow them over their first 4 years of life, we see that about 22%, or 1 in every 4.5 births, experience an allegation of harm to child welfare. Before age 4, 18% will have one of those allegations of harm screamed in. 1 out of every 7 will experience a substantiated allegation of harm, and about a quarter, or 1 in every about 4%, 1 in every 25 births will experience a removal for an allegation of harm. So a lot of kids, if we look at them from a life course perspective or over their life course, are experiencing some sort of interaction with our child welfare system, which is a big indication that maybe something's not going on in the household that's conducive to their health and development. So let's go to the next slide. And if we, instead of looking at the whole cohort over looking at the by age, if we break them apart by each year from 2009 through 2018 and look at the trajectories. So obviously the kids born back in 2019, we followed them longer, almost for 13 years. If we look in 2018, we've only followed them for about 4 years. We can see that over time, the trajectory for the proportion of kids that are experiencing an allegation of harm hasn't changed much. And so if it hasn't changed much, what are we doing for prevention is we really need to start questioning that. And so we want to really improve this trajectory so that when kids are being born today or in more recent years, their trajectory is different from kids born 10 years ago. So this is what we started digging into. So let's go to the next slide. What we really focused on were pre-birth household challenges and their impact on early childhood experiences. And when we think about pre-birth household challenges, we're really talking about those challenges that are those pre-birth household challenges that really make up the adverse childhood experiences score, or a little bit expanded score that Dr. Finkelhor and others have talked about looking at. And so if we go to the next slide, let's look at what these challenges are. So on the PRAMS survey, there's questions that asks about the mother to respond about if she experienced any of these experiences in approximately the 12 months before birth or delivery of the birth, or the birth or pregnancy. And these are the events. So did the mother say that she experienced illicit drug use, mental illness, divorce or separation, incarcerated relative, if they argued with their partner more than usual, if she was treated violently or threatened, if they had financial struggles or experienced homelessness, if a family member was hospitalized, if they moved to a new address, substance abuse or death in a close community member, job loss, work hours cut, and alcohol abuse. So you can see it's a pretty comprehensive list of household challenges that the mother may have experienced prior to that kid being born. We want to look at these household challenges and their effect. So let's go to the next slide. What we found is that kids born to mothers that experience more challenges, with the more challenges that the mother reported experiences, the higher the risk of experiencing a report to child welfare. And you can see this slide, the cumulative incidence or the risk goes up and exponentially as we start getting closer to 6 or more of those challenges. And so it makes sense. If there's a household that's experiencing more and more challenges, the probability they're going to experience contact with child welfare goes up. And let's go to the next slide. We also found, let's click through, I think there's a little bit of animation on this. For each additional pre-birth household challenges that was reported by the mother, a systematic relative increase in the average childhood ACE score was observed. So because we have that 3-year follow-up survey and we linked to child welfare, we're able to measure ACEs at age 3. And so we saw that if there's more household challenges, the kid has a higher ACEs at age 3. So it really gives us evidence that when we're talking about moving upstream, we really need to strengthen that household environment before the kid's even born, because some of these kids are quite frankly having an ACE score right at birth because there's a lot of household challenges going on. So let's go to the next slide. So we decided, well, let's look at this pre-birth environment and let's go way down the road a little bit, and let's look at educational experiences right when they enter school. So we looked at these household challenges in the period before the kid was even born, and we looked at how the kid performed on their Alaska Developmental Profile, which is a school readiness score at kindergarten. We looked at their 3rd grade reading proficiency, and we looked at their average attendance. So we wanted to say, what's the relationship between the number of pre-birth household challenges that a kid's born into, and what is the kid's performance in school? So let's go to the next slide. Or actually the animation, yeah. So what we found is that kids born to mothers who reported 4 or more pre-birth challenges, and that 4 or more came in pretty common because we saw there was kind of a divide there. And so kids that were born with 4 or more pre-birth challenges, there was 16% increased risk in scoring below their peers in their Alaska Developmental Profile and not meeting the threshold that the state has set. There's a 40% increased risk in performing below or far below on their third grade reading score, which, as we all know, is a really strong indicator of future school performance. And there's nearly a 30% increased risk in lower average attendance. So we see that the household challenges before, long time ago, before the kid was even born, have a continued effect on the kid's early educational performance. So let's go to the next slide. So to really dissect this a little bit, to look at how these factors interplay, let's just look at one of these. So if a mom reported that she was treated violently in that 12 months before birth, kids born to those mothers, 63% of them have an impulse or emotional control problems in kindergarten, 90% have poor 3rd grade reading scores, 68% were reported to Office of Children's Services, our child welfare agency, before age 9, and they'll have an ACE score that's about twice as high as their peers. And if we click the next animation, and on average, they'll have 4 coexisting stressors, and these are the coexisting stressors. The mother will likely also report having some form of mental illness, having an incarcerated relative, experiences of substance abuse, and financial issues. So it really starts helping us give a foundation of data of, while we know this stuff in the literature, we have state-based data that helps us say, you know, this is really affecting our state and our population right here. And these are the factors that are kind of meshing together that we need to address together and not separately in silos. So let's go to the next slide. So this slide has a lot on here. I'm just going to talk through it really quickly. So one of the things we were really interested in is, okay, well, we've drawn this relationship now between the pre-birth household challenges and child abuse and neglect and ACEs score and childhood education readiness. What happens if it changes and the pre-birth household changes between the pre-birth and that early childhood period? Because we have those measures on the PRAM survey and our follow-up survey at age 3. So in this time, we looked at if the number of household challenges changed between the pre-birth, the early childhood, and what's its effect on child maltreatment. And let's go to the next slide. We're going to walk through some of the results here. So we found that there were 2 distinct groups in that pre-birth period. There were kids that were born into households that had a high proportion of challenges, and there were kids that were born into households that had a low proportion of challenges. And so if you were a kid that was born into high proportion of challenges, and in your age 3, you remained in that high proportion of challenges, your risk of having contact with child welfare remained high. If we click the next animation, if you were in the high proportion and you transitioned into a low proportion, the risk decreased by 28%, or nearly 30% decrease in risk from remaining in that high risk group. If we click on the next animation, if you were low and you stayed low, your risk remained low. And if we click the last one, if you're low and your risk went high, then your risk increased by 85% relative to remaining low. Now, this might not seem like rocket science, which it's not, but what it does is it provides us now some evidence, some state evidence from our state, that if we were to invest in strengthening and addressing household challenges before the kid's born, we could expect that we would see fewer kids experiencing contact with child welfare. But it also taught us a big lesson, is that we can't just focus on one time point, that if families are dynamic, situations might change, and if kids experience challenges after or in their early childhood, that also increases risk. So we need to have connected, coordinated, and over time to address multiple time points for our prevention efforts. So let's go to the next slide. One of the things that we've also been able to do is look at some of the protections. And so there are a few questions on these surveys that ask about what are some supports or things that are in their household. And what we found is that children that were born to mothers that report if they had someone that could lend them money if they needed it, if they were help if they were sick, if they could give them a ride to a clinic if they needed it, if someone to listen to them if they needed to talk, and if they had someone they were comfortable to ask for help if they needed it. If they were reported those, they had substantially and significantly reduced risk of having contact with child welfare. The two strongest, having someone to lend them money and help them if they were sick, were the ones that ended up being the strongest in some other analyses on here. And that just gives us some indication of the types of supports and the types of infrastructure that we need to build around families to help support them, to help them deal with the challenges that they might be facing. And so to work with some of this, that's where Pat has developed using some of this data to work through his trauma-informed schoolwork. And I'm going to pass it over to him.
Thanks, Jared. I just want to say that the Alcan Link project that Jared just showed is simply the best bit of data work I've seen in 20 years working in the state of Alaska. It's providing a story of what's happening for our families and our children that I think is going to continue to pay off in years ahead. So if you could go to the next slide, I'm going to talk a little bit about one project that has come out of some of the data work with public health. And so about 4 or 5 years ago, well, actually a little longer ago, maybe 6 or 7 years ago, a group of people here in Alaska from the Department of Education, from behavioral health, from public health, our tribal partners, the domestic violence community, and others came together to respond to the trauma that we had seen in the data. And I'll show you some of that, how we got there. But we've developed for our state a framework for trauma-informed schools and a toolkit that includes videos and milestones and resources that's specifically there to help our schools respond to trauma in a way that we think is covers that whole spectrum of the pyramid that Eva showed, from prevention all the way up to clinical treatment. So if you could go to the next slide. And one of the things I think about our model, and there's some links in the slides, is that it is pretty comprehensive. It's not just about how we treat children, it's about how we treat the staff in the schools, how we engage with families, how we incorporate the culture of the community, and how we invite the community to help us create what their school is like. Professional learning, those nurses and counselors that we have in schools. What's the school board supposed to do around policy? So there's just a whole lot of what I think is a comprehensive approach to how schools can respond to some very real trauma that the data out of public health has shown us. And so if we go to the next slide, I'll show you just a little glimpse of kind of how we used ACE's data to kind of hook the local school districts and the Department of Ed, where I am, into this work. And that first measure is from 2013, when we surveyed our adults about ACEs through the behavioral risk factor surveillance system. And what we were able to show is that, look, as more ACEs occur, it's more likely that people are adults, don't graduate from high school, and are less likely to graduate from college as well. So that was the start of the conversation. Then the National Survey of Children's Health was analyzed, and we were able to look at our children's ACE scores from that survey and look at measures, all sorts of different measures that are related to schools. And you can see these two pictures on the slide are from our e-learning system at the Department of Ed that train teachers about trauma and how it impacts. So you'll see here that on the bottom there, it's the percentage of children who have been ever diagnosed with a learning disability by ACE score. And we just put Alaska and the US to show that they're very similar. It's just more likely that we're going to have more interventions for students who've experienced this trauma. So again, it makes us linked in with all the efforts on prevention. Next slide, please. So I guess before I move into this, we recently did a scan about what behavioral health services are happening in schools in Alaska. And I just want to say that our trauma framework, even though it's built around this idea of trauma, any child that experiences a severe emotional disturbance will benefit from the ideas and the structure of that program. So anyway, so we went out, and you can see some of our partners. We went out and we asked school districts how they are accessing behavioral health services in their community. And just to give you an idea, we have the Anchorage school system, which is 45,000 kids, has, I think, recently the most linguistically diverse high school in the country, to school districts with 10 children, Some of our districts are the size of states, West Virginia, Indiana. So you can imagine no roads. So really looking at what are those systems in place to support children around their behavioral health needs. And so coming back from this, we're still working on how to use this. But what we were able to do is connect districts who are solving problems in unique ways with their systems. And again, it springs from this original data work and hooking folks into it through measures from public health. Next slide, please. Here's an example from one of those reports. Again, back to the 3 tiers that Eva talked about. That tier 1, that universal, those universal prevention measures, all the way up to tier 3, which are our clinical interventions. We ask schools to think about how they're responding to kids' mental and behavioral health needs through this lens. This is a very well recognized model in schools, the multi-tiered system of support. They use it educationally, and so we can also use it around these kinds of services, and it really connects. It's not mental health with an education accent. It's actually education language. So we like that. So we went through this lens, and I'll just show you one school district's response. So if you go to the next slide. So this is a small district 9 schools unconnected by roads, think Tundra here, 359 students in the whole district. So they were starting to think about how they've learned about trauma. How are we going to get the services that we need into our schools? And so you can see they went out and actually got a telehealth solution to this. They've had the same telehealth worker for 3 years. She's doing classes virtually. She lives in St. Louis. She's not in rural Alaska. She's doing social emotional learning classes. She's doing one-on-one and group sessions with kids in these 9 different schools. And it's been a game changer. We're seeing other districts start to look at it. And again, it's just been building from these data discussions. Next slide. I just wanted you to know that we're also tapping into SAMHSA, the U.S. Department of Ed, to look at these trauma and mental health issues. We have a Project Aware grant from SAMHSA. We're in 3 districts. The Anchorage School District just got their own Project Aware. We're helping with that. And we've got, I mentioned our Trauma Engaged School Framework. At the beginning, we've got 2 research grants going on, one with us at the Department of Ed around those tools, and another one through the Association of Alaska School Boards using a coaching model. So we're excited to see how those play out and how we can see if those interventions are working and improve what we are doing. So I just wanted to let you know we're trying to blend all this together. SAMHSA, Department of Ed, and our partners. Occasionally we bring in HRSA on different things as well. We've got a small project through our partners at Behavioral Health, working with school counselors and school clinicians to support us, and that's through HRSA. So really trying to build it together. Next slide. Like I said, I guess I've kind of beat this drum pretty hard. We really think that, to Jared's point, showing that these are our kids, these are our families, these are our adults, matter when we're telling the story of what's going on. It's great to show a national study or whatever, but at least when it came to ACEs, when we could say this is us, this is what we experience, it was a game changer to get people, policymakers and others to start to pay attention. So I think that's all I've got. We've got the next slide has Jared and my contact, and I think we hit our mark on time.
Perfect. Thank you so much, Eva, Patrick, as well as Jared. What a wonderful presentation. I invite everybody to put their questions in chat. And while everybody does that, I'd like to address kind of a big question for you all. How do you market or communicate the importance of upstream prevention to partners that don't know what that is? So when you're talking to somebody, maybe at a NAMI or maybe within transportation or a different sector, how are you marketing or communicating to them the importance of upstream prevention? And we'll start maybe with Eva.
Great, thank you. That's a really good question. And I think in developing my slides today, I was constantly had that question in my mind. For us, I think it's important to talk about primary prevention first so that you have that mindset of where I am coming from. At the same time, I think it's important to understand where my partners are coming from and the crowd that I'm talking to. We talk a lot about language and how language can be different. And at the end of the day, I think it often is that we're saying the same thing. We're just using different vocabulary. So I think having that conversation and that acknowledgement and being clear about it is always very helpful. For us, we do a lot of, example of a language problem, we talk a lot about shared risk and protective factors. And that is, that can be a little over the tops of some people, and some people work in that every day, but in a different kind of way. So I think just acknowledging that and being able to, find a bridge to bridge those language gaps and know that we're working on similar things at the end of the day is always helpful when it comes to upstream prevention. Hopefully that answered your question, because it was a pretty big question.
If I can just like piggyback on that real quickly, I think one thing that we also have to understand in public health is that I've been taught from people working in the mental health space really well is that really good treatment is primary prevention for the subsequent generation. If we really take a intergenerational life course perspective here, we recognize how we're all connected and that really good treatment is primary prevention for someone else. And so if we lose sight of that, then we're gonna end up causing some problems when we go to policymakers and like, well, we'll fund this and we'll take from there. Well, we actually need a robust, seamless care across multiple time points. So we just can't lose sight of the fact that because we're focusing on primary prevention up front, that we're doing that work in public health, we're actually supporting the work of people doing treatment. And if treatment's doing it well, they're supporting the work of us doing primary prevention. So it really helps tell that narrative if you actually paint the picture to help them see that they're part of this as well.
Pat, do you have anything else to add? If not, we can move on to the next question.
I was just thinking to myself, as a social worker, I think the PhD epidemiologist just nailed it. Thank you, Jared. I love it.
Absolutely. And I'll actually piggyback off your comment, Jared. When we're thinking about upstream prevention, how does this inform legislative or state progress? How do you take this data and actually inform a new policy, whether that's telehealth or another type of policy that can help support a state in delivering youth mental health?
Pat, I mean, one thing that I can tell is that by me just sharing this information without an agenda to multiple partners, these partners have identified the connection. And so one connection is our Division of Behavioral Health saw, wow, look at this connection between these pre-birth household challenges and ACEs and the things that we're working on. And they applied for and were awarded an 1115 Medicaid waiver. That one of the parts of that was that it could make it reimbursable and billable services for providing support and services to these household challenges. And so that was one way that a policy was improved without legislative work there, right? And so anyhow, Pat, do you want to build on that?
Yeah, I was just going to piggyback on that. As part of that, we did some economic work on the cost of ACEs, and the research suggested that about 40% of our adult Medicaid was tied back to ACEs. And you lay out that number, and then you follow that up with what Jared just talked about, and you start to have a case of political appointees or legislators thinking, this makes sense. Not always easy to connect all that, but
well, and language is always changing. And one of the things that I continually find, I don't know the right word here, but hard as an epidemiologist, science-based person, and we saw this through COVID too, is that any word that can be used for trying to help support the public good can be weaponized politically. And we just always have to be cognizant of that the language we use when you're presenting in front of legislators can be misinterpreted, and they're coming with agendas. And so using common, consistent language, and I think as much as we can possibly do to communicate with our partners, so we're all communicating in a very similar language and using similar language, can really help. And I'm just going to jump right into David's question. Is that okay? Since I'm talking, David, we used Title V, which is the MCH block grant out of HRSA. They fund states to do a lot of maternal and child health work, and there's also a grant, an SSDI grant is what it's called, the Help Build Data Infrastructure to support that grant. And about 10 years ago, they really switched to wanting us to take a life course perspective. And when we realized we need to take a life course perspective, because those are really generalized funds that we can use any way we want, we were allowed to invest those into building our data infrastructure to build longitudinal data to help us understand a life course. And so we utilize these grant funds to build our infrastructure here. And that's how we use those resources, was given flexibility in funding to do what our state data tells us we needed to do, which is usually not the case with most funding. Most funding comes with like, you need to do this and measure that. So that's where it came from.
Wonderful. And I do see one other question in the chat. I want to invite everybody else. If you have more questions, please put them in the chat. I see Gabrielle had mentioned that she's starting a trauma-informed chorus in Albuquerque, and that's really wonderful because trauma-informed work belongs in all places. So I guess my question more broadly for you all is, how do you start this work? If you are at a NAMI or if you are working in a school setting, how do you get it off the ground to do some trauma-informed work? What are some of the first building blocks of that work? And I'll start with Pat, maybe, since you work in the school system.
So we started in our state outside the school system. I mean, we started with data, and we, you know, I use this metaphor of, we have a lot of data. Okay, so the metaphor is silos and silos full of data, and we have people hungry to use that data in the form of bread. But you got to have bakers. You got to have people that get to Eva's point of packaging that data, those stories to the specific audience. And you know what? It's ongoing. It's not a quick fix. It's years and years and lots of partners. And sometimes I'm the one who's to go and talk, and sometimes it's somebody else that needs to that group. And so you really need to have people pulling their egos out of it and figuring out what's the best way to get information out in ways, in a language that resonates with people, as Eva said.
Anybody like to add on to Pat's point?
Has much more experience working at the community level, and you know, I think that is, he made a great point, and I echo everything that he said.
I would say, like, one thing that I just presented, I think it was last week, for an ASTHO presentation on ACEs, and Pat, being a little bit modest here, is that he was a champion for getting ACEs work. He communicated, he presented, he did the bootstrap work and going and making it accessible to people, and he was our baker. I love the analogy. I'm going to steal it, Pat, even though I'm a horrible baker. But you need your bakers, right? And I don't know how much more to reiterate that, to be able to communicate. And so Pat did all that work for us up front to just start that communication. And it really started with conversations and seeing Pat present these things and seeing his slides evolve into things, and then the ones that stick. And the slides that stick are the ones that really show impact and that resonate at that local level. And when you have people that can connect to the data, it's pretty impressive.
Well, and I also think, I mean, the other thing is, I remember going to a school district one time and the superintendent said, we're going to split our staff. You're going to have half of them. Dr. Linda Chamberlain, one of our colleagues here, who does some really amazing brain work, and it's kind of touchy-feely. She goes, he said, she's going to have the other part, and then we're going to switch. And he said, Pat, I want you to be the numbers, data, you know, nerd guy. And I will say that was a smart approach, because between the two of us, not necessarily presenting together, I think we hit a much higher percentage of people than if it had been one of us or the other. You know, some people glaze over with the data, some people glaze over with the stories, but really trying to, you know, find your way to everyone in the crowd matters.
I see one more question in the chat. Well, I'll ask another question, and while you're all addressing that, I will read that. I wanted to see from you all, we've talked a lot about convening different sectors and partners and the importance of data, but at what point is public health a convener? And at what point do they have to be humble and pull a seat to the table? And so that's something that I've heard a lot in some of the work I've done recently. So I'd love to hear from your perspective. When should public health be more humble and pull a seat to the youth mental health table? And when is it appropriate for them to be the conveners?
That's a loaded question to ask 3 public health people in a room full of mental health. I don't know that I quite have an answer for that. I mean, I think that I think we both have, I think it's, it's sharing, it's open, it's sharing, and it's being willing to hear what the other is saying, like any great relationship, and vice versa. And so I don't know that I have an exact example or time to say when it is time for public health to pull up a seat, or vice versa. I think it's a learning curve, and I think that we're trying to work through it as best we can. Patrick, Jared, I'd be interested y'all's perspective, just having more hands-on experience with local and state communities.
Jared, I'll go ahead. I have a lot of opinions. So I used to work for public health, and now I work for the Department of Ed. I've worked in behavioral health. Other than maybe I can't hold a job, it's given me some interesting perspective. And I think public health brings an amazing sense of using data, the public health process. I think that's important. SAMHSA, in terms of prevention, and at least behavioral health in Alaska, using the strategic prevention framework, 12 years ago, really has jump-started the community prevention efforts in our state. And I think those are the ones that are grasping onto this work in a very smart way. And so I think public health is a little later to that game, but you also bring resources that I think are valuable. So I think it's, it is always approaching it humbly, and building those relationships so that somebody can say to you, no, and have it be a safe place to do that, because it's hard work. Jared's just done an amazing job of braiding resources from all over to do this work. And he listens. I think when Jared got together with the founder of our trauma center, that was an amazing synthesis of 2 worlds that's really paid off over and over. They listened to each other and learned.
I'm just going to add on that I think that we need to recognize people's expertise and training and not belittle them. One of the things that I get pet peeves sometimes when I see public health work done by people who don't have any public health training, and it cheapens it. And when I see other work done by people who don't have the training, and so I always say that recognize people's expertise and bring them to the table. And for public health, I think our best work is done when we focus on the population at large, and we're the things that are basically applicable to most people. And we want to specialize and focalize. Let's get the experts at the table and work with them and have them leading the charge there. And as long as we can recognize people's expertise and bring them in there, we're going to have some amazing work that occurs. We're always going to have problems, but at least we can recognize people's expertise at the table.
Absolutely. And the reason I asked that, I should say, as a small plug, is that ASTHO has been working on developing a public health approach to mental health promotion framework. And that's one of the questions that keeps coming up throughout this work and working with communities. When is public health a convener, and when are they pulling a seat to the table? So that's where this question came to be. And that's a plug for everybody. Look out in late summer, early October, September, that there will be a framework that's published. And our last question before we move on to ending the webinar is, how do you work on trauma-informed practice with staff that also experience trauma regularly?
So I'll jump in again. So if you look at the framework, that wheel of chapters from our framework, one is self-care. I wish we hadn't called it that. I would call it staff support. We have found that the entryway into what we call trauma-engaged work is often the best way to do that is to start with the staff and their emotional life and their stressors, because what we found is when you start there, people start to recognize their own stress and how it impacts their work and their lives. and then it makes it easier to make that leap into the system. We talk a lot about with kids about regulation, self-regulation, and where does that come from? It's kids learn that from co-regulation, co-regulating with adults. And so we got to have the adults working with families and kids in a healthy place. It's just essential. And so that's I think the best place to start.
Okay, I'm just going to add 2 cents. First, I think that this is probably the most important question that's been asked. And that if we can't build something that we ourselves won't do, then it's not going to be working for those that we want them to do. And that's one of my biggest things that I always look at with the public health model, is that if this is for someone else, then why am I even doing it if I wouldn't do it? Because then why would I expect them to do it? So if it's not going to work for us, then it's not going to work for them. So I would first and foremost make sure that we're healthy and focus on making sure we're really, really healthy to serve the populations we're doing. That's the exact same thing we're trying to do for families. Make sure parents are healthy so they can raise their kids, so they can have all the supports they need. So that's I would put my focus 100% on making sure that my staff are supported and that this trauma engaged work is working for them first and foremost. And then second, I would recognize one of the things that I always love doing is when I'm sharing data and someone comes up after the presentation says, how does this data predict my life? How am I represented like this? I don't get it, how your data is so accurate. And then to start engaging them in being like, start moving people with lived experience into being solution oriented. And it helps them address that issue that they've had because they start seeing solutions as opposed to barriers.
That was a great ending, Pat and Jared. Really appreciate it. I am going to transition it back to Kelly to close us out. Thank you all.
Yes, special thanks to our presenters and to SAMHSA for sponsoring today's webinar. We do ask that you fill out the survey at the end of the presentation. It will show up when you leave the room. Thanks again for joining us and enjoy the rest of your afternoon. Take care. Bye.